Hi, good evening, everybody. Welcome to another edition of Hand in Focus. Our theme tonight is finger fractures. And thank you all for joining us tonight. My name is Harvey Chim from the University of Florida, and I'll be moderating this session together with Carl Eberlin from Mass General. Our first paper that we'll be discussing tonight is entitled Morphological Analysis of Metacarpal Shafts with respect to retrograde intramedullary headless screw fixation. And we have Dr. Michael Darowish, who's joining us today to discuss this paper. Our second paper we'll be discussing tonight is entitled Percutaneous Fixation of Unstable Proximal Phalanx Fractures, a Biomechanical Study. And we have Dr. Robert Strauch joining us tonight. Our expert tonight is Dr. Chaitanya Mudgal. He's Associate Professor of Orthopaedic Surgery at Mass General Hospital, Harvard Medical School, as well as the immediate past chair of the AO Trauma Hand Committee in North America. He's an expert in finger fractures, and we're so happy to have him tonight with us. So as for previous editions of Hand in Focus, our format will consist of two sessions to discuss the two different papers, which will start with an author presentation, followed by a brief discussion by residents and fellows from MGH, who will discuss the articles and how it will affect the new practice. Tonight, we have Dr. Tuano and Dr. Cole who will be joining us for the session. And finally, for each session, we have Chai Mudgal, our expert, just deliver his take on each paper. And this will be followed by a Q&A session. So please mute your microphones. Your camera should be off while the speakers are presenting. Cameras can be turned on for the Q&A. And please make sure your name is displayed. And please ask questions because we really want this session to be engaging and interactive. So Carl, do you want to say anything before we get started?
Yeah, I just wanted to welcome everyone and really encourage everyone to ask questions in the chat. Dr. Chim and I will be really following those carefully and make sure that we incorporate that into the discussion.
Yep. So without further ado, I'd like to invite Dr. Darowish to discuss his paper. Mike, please.
Good evening, and thank you for joining us. So I'll be talking about a paper that I did with one of our residents and a med student here, looking at the morphologic analysis of metacarpal shafts with regard to retrograde intramedullary headless screw fixation. So we are several years after we started this paper. So when we started our research, this was what was being published about the use of intermedullary screws. And you can see that these were being reported as a new way of taking care of this, and it was a bit cutting edge at that time. And the results that were being reported were reasonable by those who had adopted it, but there were several doubters. And when we looked at the papers that were reporting it, you can see that there were, as hand surgeons, we're used to using hand screws. So we were using 2.4 and 3.0 millimeter headless screws because that's what we're used to using. And we're putting it into these huge stovepipe fingers. So this is what people were publishing, is this undersized screw in a metacarpal. And even the esteemed Dr. Mudgal, this is one of his papers, and he was using these 2.4 and 3.0 millimeter screws. And as you can see in the ring finger, it's great, but in the small finger, though he got an outstanding clinical result, there's not really much purchase achieved. And so we set out to look at, as hand surgeons, we need to realize that we needed potentially different tools in our toolbox to be able to utilize this technique, because it clearly has some distinct advantages over plates and screws, less hardware irritation, smaller dissection. But to get acceptable purchase, you need to grab this. And especially for axial or for rotationally unstable fractures, where we're really relying on getting purchase to keep it from rotating, relying on this tiny little screw head was a little bit challenging. So as I looked at this, I said, would we accept fixation like that in any other bone? Can we imagine fixing a tibia with a tiny non-lock nail that's not engaging the inner cortex, and especially as we're trying to control for malrotation? So at the time, the screws that were available to us were sort of outlined here from this Journal of Hand Surgery article, where we're looking at diameters of the leading threads of 2.5 to 4.0, and the trailing threads were bigger. And our lengths were also significantly limited. Even the longest sets of screws were coming in 40 millimeter lengths. And then if you upsize to the foot implants, which was really what they were considered at that time, when you looked at something from Synthes, they had these are the the 4.5 millimeter headless screws, and these are the 6.5 millimeter headless screws, or the larger AccuTrack screws. You have bigger options available, and you started getting into longer lengths, which is what you would need for some of these more proximal metacarpal fractures. So as Dr. Mudgal will show, he did a very fancy study where they looked at these three-dimensional models, and they showed that, you know, the concern was you're going to make this big hole in the metacarpal head, and people were really frightened of that. And so I did not have this kind of wherewithal to do a fancy study like this. So we went to the lab and we got a cadaver, and I drilled big holes to sort of prove to myself that this was acceptable. And you can see we drilled a big hole here. This is a 4.5 millimeter hole, but when you put it into full extension, it's really not even articulating with the hole that you make. And it's not until you get into hyperextension that it even articulates. So that made me feel better that, okay, this is something that we can do, and putting a big screw in makes some sense. So then the question is, what should we be doing? So this is one of my initial cases where I was like, this is something that I think would be well treated with a retrograde screw, but in a small finger, you can have a pretty major canal. So here I was worried about, it was a malrotated fracture. So I ended up putting a 4 millimeter diameter screw down, and I got reasonable purchase, and it went on to heal well. We had previously done studies looking at the opposite problem. So when we looked for doing a headless compression screw for DIP fusions, our study showed that you have to be really careful and not oversize the screw, because a lot of fingers are not large enough to accommodate even a 2.4 millimeter screw. And so we published this study, and as soon as we submitted it, this better study came out that not only looked at the diameters, but also looked at the length that you would need to achieve it. And so we learned from our mistakes on our previous study, and instead of doing just AP and lateral dimensions here, we also took into account length, and we used a CT scan this time. So we went and we measured both the anterior to posterior and radial to ulnar diameters of the medullary canal at its narrowest point, and then we measured from the metacarpal head back to where we felt the narrowest point was, to get a sense of how big of a screw can we fit, and how long of a screw do you need to get that isthmic purchase. And so what we found was that, much like somewhat unexpected, the small finger was actually quite large with its intramedullary canal diameter. The ring finger is the smallest, and that is very much in our experience as hand surgeons, that as you're sizing silicone MCP implants, it's that ring finger metacarpal that is often the rate limiting side on what size of an implant you can get in. And what we found was that over half the fingers needed a screw more than 3 millimeters in diameter to get that inner purchase, and at least 40% of index, middle, and small fingers needed bigger than a 3.5 millimeter diameter. And then we also found that oftentimes you needed a length longer than 40 millimeters to get down into that isthmic purchase. So this is interesting. This is off the Arthrex website in their technique guide and their technique video. And you can see you've got this K-wire down, and it's this stovepipe to get any purchase into the small finger. And then the ring finger is very narrow. And that's what you find clinically as you're trying to decide what implants you need to have available to be able to appropriately fix these using this technique. In 2022, there are now different implants available to us, which have addressed these very issues that were raised by us and by other papers. There are now wider diameter intramedullary implants, longer intramedullary implants. There are intramedullary implants that do and intramedullary implants that do not compress. So now you have the ability to use these implants not only for simple fractures, but for length unstable fractures where you're not going to compress them together. I would advise, and this is editorial, if you select to use the TriMed system, please be aware that they have decided to name their implants different than every other implant on the market. So every other implant on the market for a headless compression screw is named based on the thread diameter at the leading threads, and the TriMed has elected to name theirs by their core diameter and not by their thread diameter. So if you are selecting your implant, know what you're asking for, because they've elected to use a different naming convention than every other headless screw on the market for this purpose. And then after we submitted our study, other studies have come out stating exactly the same thing. Another study out of the group at Rothman, very similar to we had one and they had one, we had one and they had one, and theirs is looking at bony dimensions, both diameter and in length, pointing out that you need longer lengths to be able to do this, as well as Dr. Jones and his group, again, saying that you need longer lengths to be able to get down into the isthmus. So overall, you know, if you are willing to adopt this technique, which I think makes all the sense in the world, knowing that you have the correct implants, knowing that a 2-4 headless screw might not be what you need. You might need a longer implant, you might need a wider diameter implant, and choosing intelligently, do you want to compress, do you not want to compress? What kind of fixation are you looking for? And how are you going to feel comfortable so that you can get those patients moving early is going to be critical.
Great, that was outstanding. Thank you so much, Mike. Next, I'd like to invite Dr. Tuano to share her thoughts about this paper. Crystal, please.
Yeah, thank you so much. Good evening, everyone. Thank you for joining us. I thought this paper was a great review and a reminder to me that you cannot emphasize enough how important preoperative planning is. And not to be redundant about things, but I think that it's a great thing to know preoperatively that in general, the ring finger is going to be the smallest average, and the small finger is going to have the largest average diameter. So you can kind of plan for what you're going to do in the operating room in terms of getting equipment and things like that, and what you would need in terms of a secondary plan if things didn't work out how you were intending to initially. I thought some other really interesting points that I think are going to be useful for me in my future practice, and I think are good for trainees in general to keep in mind, is that the radial ulnar dimension was the rate limiting dimension in the index, middle, and the ring finger. And the volar dorsal was the smallest dimension in the small finger. So I think if you don't have the ability to get CT scans, or if you didn't have them preoperatively, but you do have adequate x-rays, I think it's good to be able to keep that in mind and perhaps measure them just from the x-rays themselves. And I think another thing that, to think about is that study that was referenced also in the paper that Dr. Mohammed et al. Did with the 44 cadaveric metacarpals in comparison to the inferior load to failure. It was based on a hardware that was 2.4 millimeters in diameter. So I think it's so critical and important to really have a good preoperative plan to ensure that you have necessary cortical purchase with the isthmus, because otherwise you can't really improve the biomechanical stability of your construct. And then, for discussion points later on, I think some things that I wanted to discuss and hear people's thoughts are on preoperative CT scans and how often you're getting those in practice in comparison to the plain films and using those for your measurements. And if you're in the operating room, even though you had preoperative planning and were able to request the equipment you wanted, let's say you didn't have one that was long enough, or you didn't have one that you thought was had the adequate diameter, what is your first go-to as a secondary plan and perhaps a tertiary plan? Thank you so much.
Great, thank you. Those are really all great points. And I think we'll try to get to those questions in a little bit. Next, I'd like to invite Dr. Mudgal, our expert, to give his take on this paper. Chai, please.
Thanks very much, guys. Thanks to Harvey, Kyle, AHS, and to all the crews gathered here. This is going to be fun. I'm just going to share some personal philosophy and thoughts I have about this. So when I first published this technique about 12 years ago, I was basically told that I was nuts. And one of the criticisms directed at me was that I was creating a hole in the articular cartilage, and oh my God, what are you doing? That's anathema. And what will happen? You'll get arthritis, etc., etc. People were worried that it would cause compression, it would cause shortening, and there would be no rotational control at all. Okay. In defense, the size of the metacarpal head is reasonably similar to the size of the proximal pole of the scaphoid. We put screws in the scaphoid with impunity. We put screws in the capitellum and the radial head with impunity through the articular surface. But yet, when you did that to the metacarpal, everyone was up in arms. So that one went by the wayside. Secondly, people said, well, you won't get rotary control. But this is a screw which has, the screw I was using at the time has threads at both ends. So it gave reasonable rotary control as long as you are engaged in the subchondral bone, which has high trabecular density. And finally, when people said, well, if you use that articular surface, you're going to create arthritic change. So when nothing makes sense, you go to the lab, and that's what we did. So we looked at a quantitative 3D analysis of the metacarpal heads. And what you have to remember is that the MP joint in human beings is blessed with 30 degrees of hyperextension almost. So the part of the metacarpal head is clearly not utilized for activities of functional daily living. And what we found was, you looked at the mated surface of the metacarpophalangeal joint, and the 3 millimeter headless screw engaged only in 8% and 4% of the mated surfaces in the coronal and sagittal planes, all of which were completely irrelevant to functional activity. So what are my keys to success? Template, template, template. And this was in the days before we had such a plethora of choices of screws. You have to be careful about making sure that you have a starting point in the dorsal 1/3 of the metacarpal head. And I traditionally use these screws that I've shown here, 2.4 for the 4th metacarpal and 3.0 for the others. Now, Michael's points are well taken about the sizes of the screws. So I'll come to that in just a second. What does the data tell us thus far? That in the last 12 years, there's been more than 60 papers published on this technique. I guess it's catching on. 1,100 fractures, most have functional outcomes which are excellent, and the complication rate is just about 3.5%. And most people would agree that they're biomechanically stable, although some studies suggest that that's not the case, or it suffers in comparison to plates and screws. What is my own personal experience? I don't fix every metacarpal fracture with this technique, mind you. You have to be selective, and Rob Strauch and I agree on that. A lot of metacarpal fractures can be treated just fine non-operatively. So in 40 fractures, we've had total active motion in most patients. We've had one bent asymptomatic screw, which at the time of surgery and discharge looked like this. But when he came back to sign up for the armed services, looked like this. He didn't have any symptoms, and he had perfect function, so we left him alone. But that's okay if it's just one person talking about it. It may not represent other people's experiences. So we did a multi-center study, and we looked at 160 patients, retrospective, obviously. The complication rate was 2.5% with 1 nickel allergy, 2 bent screws, and 1 broken screw. So some things to bear in mind with respect to what Michael's study says. I have traditionally looked at this not as a compression screw, although it is called a headless compression screw. I look at it more as an internal splint. Now, during insertion, it is very critical that, let's say you're putting a screw in my left hand, and as I'm turning with my right hand, I'm torquing on it. And the torque, as the trailing threads engage, will force this into internal rotation, the head's fragment. And conversely, on the other side, into external rotation if you're doing the other hand. So it is paramount for the surgeon to flex the MP joint fully so that the collateral ligaments are on stretch at full length, and that prevents malrotation as you engage the trailing threads. If there is concern about the size and the patulus of the medullary canal and you don't have the right size screws as suggested by Michael, then it is okay. Just drill the head, do not drill the shaft. You will get purchase. The other thing to consider is, when I initially wrote up this technique, my thinking was that you had to get isthmic purchase. Since then, I've become a little more flexible about that thought process, because I oftentimes wonder if it can work on a three-point principle. This is the slide which I borrowed from Michael's talk. And if you look at this in the middle here, can you see my cursor? You're going to see that the metacarpal, even though it has a straight dorsal surface, has a curvature on the undersurface. Therefore, these screws can actually work as a three-point fixation with 1 point in the head, 1 point along the shaft, and 1 point proximally. And this is where I think you have a little wiggle room that even if you don't have the right size screws, you don't need to panic, because oftentimes these screws will still work on this three-point principle. Additionally, if there's concern about stability, you can augment using other principles. And finally, if you don't have the right length, in a pinch, you can always bury them a little bit deeper, as I'll show you here. Now you look at this person here, a heavy object fell on the third metacarpal, and you got an extremely comminuted metacarpal head, neck, everything. Now there's no way you can fix this with a plate and screws, so we made this up as we went along. Fixed the head fracture with a headless screw, engaged length restoration with a cannulated screw. Again, this was the longest screw we could use, but I was not happy with my rotation. So I used a threaded K-wire, and I used it as a secondary form of stack nailing, if you want to call it that. It's an old orthopedic principle. I was not happy with the amount of comminution, so I added a cerclage, another orthopedic principle. And then finally, for further rotary control, I added a sidewinder. All of these are established techniques, and there's nothing that says you can't mix and match them. So be willing to be flexible. And if you don't have the right size screws, of course, you want to have the right size screws if possible, but if not, be willing to take on other techniques. Finally, when you look at this and you have mutilating hand trauma with multiple dysvascular digits, you really want to get on with the micro work as quickly as possible. So in situations like this, in this case, we sacrificed the small finger. We quickly fixed the second and the third and the fourth with headless screws. As you can see, I had to bury one quite far down, and the second was too far for me to consider burying it. So I just fixed it with threaded K wires, which I removed later. And this is at about 8 weeks or so, and he was doing very well. He has done even better since. Now, the last thing I would encourage all of you to bear in mind is when you think that you really hit the jackpot, you're the cat's whiskers, and you really innovated, came up with something new, think again. Because people have gone before you who had the same ideas. My good friend Tom Fisher sent me this picture from Gottfried Segmüller's book from the 1968 to 72 era, where the same idea had been thought about. So don't get a big head because someone else has thought about it before.
Great, great. Thank you so much, Chai. That was really outstanding. It's really a treat to hear from you. You have so much experience with this technique. I'd like to start actually by asking our panelists, obviously this is such a powerful technique, but are there operative metacarpal fractures they would not use this technique for? They would still use a plate and screws or some other form of fixation? Chai, would you use a screw for like basically every fracture,
No.
metacarpal fracture?
So I've gone away from using, metacarpal fractures are divided into two categories, basically, wall punchers and non-wall punchers. For wall punchers, I try not to use the screw if I can establish that their approach to life is suboptimal. If they are reasonably, just someone who had a momentary lapse of judgment, I try to get a sense of them. I will use a headless screw for them. But if they are not, if I think that they have, supratentorial problems, then it's best not to use an IM screw, because you saw from the case I showed you, if they punch once, they'll punch again.
That's a great point. How about you, Mike? Any comments?
I think I would echo what Dr. Mudgal said. I don't fix most metacarpal fractures. And frankly, for wall punchers, I try to not fix them, period. I try to treat them non-operatively because we know that they do very well non-operatively.
Yes.
So for me, I think patient selection is critical. I think selecting the fractures that actually need to be fixed is critical. And Dr. Stern at this year's hand meeting sort of showed this horrendously angulated 4 metacarpal fractures, and he said, who would fix this? And every hand in the room went up, and he's like, yep, here's the kid. They're all 70 degrees angulated, and he has full motion. And so it made you think, which one should we actually be fixing? I think that in a highly comminuted fracture, you have to be, it can be very challenging to fix those with a intramedullary device, and they can be challenging, period. But those are ones where if I'm really worried about length, even with a non-compressive intramedullary implant, I may consider plating those instead. I think where I get the most bang for the buck with the intramedullary is for the more distal fractures, where putting a plate on, you're almost guaranteeing yourself tendon adhesions and causing problems and needing to do hardware removal. I think that's where I really lean towards doing the intramedullary fixation.
Yeah, those are really great points. I want to spend some time also addressing one of Crystal's questions. I think, Crystal, you had asked about whether you guys routinely use CT to template the size of your screws. So do you guys do that, or do you just use X-rays to measure the size of your screws beforehand?
So I routinely just use X-rays, and I use it as my first pass. I measure it, and so I know what my first guess is going to be. And then before I put the implant down, I'll hold it up against the metacarpal on the mini C-arm to make sure that I'm not fooling myself that it's the right size. So I have a template, and then I double check by holding it up, and then I'll actually implant it.
Yeah, I think with the current generation of digital software that we have for radiography, the PACS system, it's fairly accurate. So it allows you to do preoperative templating quite accurately. And I use that routinely. I rarely feel the need to use CTs. If they come to me with a CT done someplace, that's fine, but I don't go after it.
Yeah, those are great points. And I think CT also adds to the cost of treating these patients, and that's definitely a concern. So, Michael, I want to ask you, your study, was so enlightening about the size of the metacarpal canal. So what size screws do you use nowadays? Do you have a standard that you use like Chai, 2.4 millimeter and 3.0, or do you, what do you use nowadays?
No, so I template, I do exactly what I said. I measure it on the X-ray, and based on what I see, depending on whether I feel like I can compress or not, I'll ask the reps to bring in various sizes, whether it's not, I don't get paid by any of the companies, but I'll ask them to bring different sizes. And if I'm using the Exosmet, they routinely will bring both the 3.2 and the 4.5s in for me and have them available. If I'm thinking otherwise, I'll ask them to have multiple sizes. And if you're a Synthes person, the new headless screws are nice because you have multiple choices in one box, and you don't have to bring 6 sets in. You've got 2, 2.5, 3.0, 3.5, and 4.0 all there for you, so you can choose on the fly rather than having to bring in 6 sets like you used to have to do.
That's a great point. I want to address a question by Dr. Stuart Proper in the chat as well. He asked, given the screw thread is the widest part of the screw and the isthmus the narrowest part of the canal, should we be aiming only to get grip in the isthmus, or should we be aiming to pass all threads past the isthmus? And I think you kind of alluded to some of this in your talk, Chai. So what's your take on this?
So I think that's a very valid point. And when I wrote up this technique, I was thinking, that we should have isthmic perches. And since then, like I said, I've gone away from that. But one thing I agree with Michael is that the current generation screws, what they've done is they've given us length, and that length is a huge boon. So I'm not entirely convinced that you need to have isthmic perches, because like I said, if you look at the metacarpal, the dorsal surface is flat, but the volar surface is angled, thereby creating this arch effect. And thereby, I think even if you have a slightly undersized screw, it will still give you reasonable perches because of getting those 3 points that I talked about. I haven't proved it yet in the lab, but that's my thought process. So
I would also add in that it depends on where your fracture is.
Yeah.
How far down you have to get, because if you're using this for a fracture that's just above the isthmus, just like any nail, you've got to get way past it. Whereas if you're putting it in for a more distal or metacarpal neck fracture, as long as you're getting some proximal purchase, you're okay. And that's where I think that I completely respect Dr. Mudgal. I think that having a bigger screw and getting a bigger head in and grabbing more bone in that metaphyseal area so that I have better purchase up there, I sleep better at night with a bigger screw up there than I do with a 2-4 and hoping that it doesn't spin around it.
No, that's a great technical point. Rob, you have a question as well or comment?
Yes, can I share my screen for a second?
Yes, please.
I'm just going to show one picture here. We talked about the 8 fingers, but we didn't mention the thumb. Do you have any feelings about the thumb? The canal, I think, is probably arguably the biggest of all of the metacarpal bones. And what do you think about the size screw for something like this? I'll tell you, I did this case a few weeks ago, and we used an intramedullary screw. Here, and just as Chai was talking about, you can see it gets that 3-point purchase, Chai. You see it's engaging that palmar aspect, and I think that's what allowed us to get a good reduction and maintain it with this.
That's a great X-ray.
The one thing I would say, I think that is very illustrative of what I was thinking about. The one thing I worry about, Michael, is that when you make these, so when you look at those cadaver pictures that you showed, right? And you make your hole, the starting hole, in line with the medullary canal, if you go slightly more dorsal than you ought to be, and you use a slightly larger headed screw, the trailing threads, one of the things that I've had happen to me is that as I turned the last threads, I created this hoop stress, and I had a fracture line generate, and that just compromised the whole thing. Of course, I had to use a bailout method for that, but that's the one thing I worry about when you go larger with the trailing threads. That's the thing.
Yeah, I'm going to turn it over to Kyle. Kyle has a question.
Yeah, we have to move on to the next paper soon, but this discussion has been excellent. I wanted to ask our 3 experts if there are any cases in which you would not use this technique given degree of contamination or worry about the possibility of hardware removal in the future. Well, maybe a quick answer from each person, we'll move on. Chai, what about you?
Well, I showed you that was a wood chipper injury that I used it for. And I'm reasonably comfortable doing that just so I can get to saving the hand.
I'm not so worried about hardware removal. We remove intermedullary screws from DIP fusions that are symptomatic. So getting this out is not particularly much different than that.
All right, great. We'll move on to the second paper. The second paper is entitled Percutaneous Fixation of Unstable Proximal Phalanx Fractures, a Biomechanical Study. And Dr. Strauch will be presenting that paper first. Rob, go ahead.
Okay, can you see my screen there?
We do not see it yet.
Not just yet.
Figure that out. Oh, it says someone else is sharing.
Oh, hang on. Was that me?
Don't know.
I don't think anyone's sharing just yet.
Okay, let's try this one. Can you see that? No?
Not yet.
Not yet.
Okay. Let's try this one. Now?
There we go.
Okay.
Yep.
Good.
That's
Yes, now we see you.
All right. So there was a book that you may know about. Everything I ever really needed to learn, I learned in kindergarten. That was famous a while ago. And this was my kindergarten for hand surgery. This was back in Indianapolis, 91, 92. Chai was there for a little while. And we have fellows of Tom Wiedrich, Jeff Greenberg, myself, Chris Lechner, John Hogikian, and Mike Bednar. And pretty much everything I learned about treating hand fractures came from that time, and it hasn't changed very much since then. So the Indiana group at that time was a real scholarly powerhouse. This was an article that's cited in most articles of finger fractures that you need to get them moving by 3 to 4 weeks. And yet this article is not on PubMed. You can't find it on PubMed, and it doesn't link to anything in Google Scholars. So if anybody wants a copy of this article, email me and I'll send you a copy. We had to get it to an interlibrary alone. But this is a often cited articles saying that you need to get finger fractures moving within 3 to 4 weeks, or they don't do so well. Also from Indianapolis, Hill Hastings had a nice paper showing that for the proximal phalanx, if the skeleton shortens a millimeter, that will give you a 12-degree extensor PIP leg, and it gets worse the more you shorten. You also will get shortening of the skeleton with apex palmar angulation, such that if you have about a 30-degree angulation, you're going to get a 25-degree extensor leg. And that is because when you palmarly angulate the fracture, the skeleton shortens by a trigonometric method. This patient came to me about a month ago, 43-year-old gentleman with a 2.5-week-old base of proximal phalanx fracture with significant apex palmar angulation. And you know, right away, he's 2.5 weeks out, he's not going to do so well. This was also noted in a paper by Drs. Eberlin and Mudgal, where they talked about their technique of cross-pinning of these proximal phalanx fractures. And they noted that if on the initial lateral view there was angulation greater than 20 degrees, they didn't do so well, and chemolysis may be required. But they had pretty good results. And that may be because they operated within a week of the injury. And this was their technique of cross K-wire pinning of the fracture. Belsky and Eaton and Lou Lane described a technique in 1984 of transarticular pinning of the proximal phalanx fractures. And this was mostly done for the transverse and the short oblique fractures. For the long spiral fractures and long oblique fractures, in this article, he recommended transverse pinning perpendicular to the axis of the bone, such as you would do for lag screws. They had really good results. In 90% of cases, they had good or excellent results, but these were also treated within 5 days. And this is an easy technique. You just put it through the metacarpal head down the shaft of the proximal phalanx. I think it's easier than the cross K-wire pinning. There is thought, though, that it limits the extensor mechanism, and this is an article by Mark Barrett and co-authors showing that if you put the K-wire through the center of the central tendon, you lose 34 degrees of flexion at the PIP joint. And if you insert it laterally, you only lose about 12 degrees of PIP joint flexion while the K-wire is in, obviously, not necessarily permanently, because you're skewering less of the extensor mechanism. Not everybody has good results with this technique, and Peter Stern and his colleagues, as we know, are very much truth tellers and reporters of complications. And in their series, this was actually a misnomer of a title. This was actually a comparison between cross K-wire pinning and the trans-articular pinning described by Belsky. And they found about equal results, but they didn't do that great. In the materials and methods, they operated on patients within 2 weeks. So it didn't say really at what time they were operated on. But a lot of them ended up with both flexion contractures of the PIP joint as well as loss of flexion of the PIP joint. And it was about the same. Maybe the transarticular pinnings did a little bit worse. I've always been inclined towards the Belsky method, and it seemed a little bit easier to me. You could get maybe 3 points of fixation in comminuted fractures. In the paper by Kyle's paper and Chai's paper, half of their fractures were comminuted, which you would expect might shorten a little bit since there's really no length stable fixation there. But if you do a transarticular pinning where you go through the metacarpal head, the base of the proximal phalanx, and you anchor it in the subchondral bone of the proximal phalanx, it seemed to me that you get 3 points of fixation as opposed to the extraarticular pinning where you're only getting 2 points of fixation, the base of the proximal phalanx and the distal pin interface. So it was another point of a friction fixation, like a locked nail almost. I thought it would be better to prevent shortening of comminuted fractures with the Belsky method. So we designed a study to see if that was the case. We created a fracture model simulating a very comminuted P1 fracture, and we compared the transarticular Belsky method to the cross K-wire pinning. For the Belsky method, we used either 1 K-wire or 2 K-wires that were centrally placed, and all of the extraarticular pins had 2 cross K-wires. And in fact, we didn't find really much of a difference at all. This is that patient, that 43-year-old. I was able to get it reduced closed with a little percutaneous Kapanji pinning, breaking up of the fracture. And this was him post-op. This one actually developed an interesting complication when I saw him at the 2-week mark. Look at his PIP joint. He had very hyperextensible PIP joints. And I had him moving in the splint. And when we put the pins in, we had him in full flexion at the PIP joint. He showed up with this like 60-degree hyperextension deformity of the PIP joint. And I had to block him to get him to come down again. And it's starting to get better, but never seen that before. So thank you very much.
Great. That was an excellent presentation. Let's move on to Dr. Justin Coe, one of the MGH fellows who's going to discuss his perspective on this paper, and then we'll move to Dr. Mudgal.
Thanks, everybody. Thanks for the organizers, Dr. Strauch, for the background of this paper, which is a very cleverly designed way to evaluate the biomechanics of this problem. I'm sure all of us in our practice seen 10,000 different ways to skin a cat, and you're talking about intramedullary fixation as well, too. I remember very distinctly at the Exos Med course seeing everything from the A-frame or different intramedullary options for P1 fractures as well. With all this variability, and in practice, it's good to really be careful about evaluating what the best method is and what the different theoretical benefits are. And clearly it's a problem where we have many, many different fracture patterns. We have a lot of different ways that we can create this axial instability. So I thought the paper did a really clever job of creating about the most axially unstable situation by removing a 5mm void before trying the different pinning methods. Very pertinent to my own experience this year as a fellow at Mass General. Oftentimes when we're pinning these fractures, a lot of times our hands are a little bit tied with what our fixation methods are, how many pins we can use, what pin configuration we can use by the soft tissue envelope and the severity of the trauma that can be associated with it. Which the main takeaway that I got from this paper is very reassuring that, even if your hands are tied, even if you're limited to a single pin in one configuration or another, if you're only able to get a single pin through an Eden-Belson configuration that's sufficient to, or equivalent really biomechanically to stand up to similar axial loading stresses and subsidence compared to other pinning configurations. And can really be applied broadly to many other to almost every finger except for the small finger that was obviously excluded in this particular paper. And as I mentioned, as we're well aware, there's many other factors that play into different deforming forces and stability pattern with respect to other deforming forces such as rotation, et cetera, that can factor into your exact twist configuration. But it's absolutely, for me, a great comfort to know that in acute settings, much like Dr. Mudgal was mentioning with the mangled hand situation, when you want to get your fixation as expeditiously as possible before moving on to everything else in a high energy trauma situation, that less is more. You can work with what you're given to get a stable construct and then move on with the rest of the stabilization.
Great. Thanks, Justin. Let's move on to Dr. Mudgal to share his expert opinion, and then we'll have a great discussion, I'm sure.
All right.
And maybe you can tell us why they call it Eaton-Belsky pinning, even though it's Belsky-Eaton in the actual order of the authors.
Yeah. Just like the paper that we published on the IM screw never references my name, so that's okay. It's always called the paper by Bolton and colleagues. So, but that's life. So much like Michael's paper, this paper by Robert, these are just fantastic papers, and each of them have a very important message about what we do for these fractures. So I agree with Robert on several features that he's mentioned, but I'll give you some technical tips and then have some comments. In small finger P1 fractures, to get a true AP view, you want to elevate the ulnar border of the hand by 20 degrees. Otherwise, it's very hard to assess coronal plane deformities of the P1 in the small finger because of the arch of the hand. Just take a PA view that the radiographers give you. It's hard to get a true PA view. And in the technique by Belsky and colleagues, I try to minimize MP flexion. I want all the audience to do one thing. Flex your MP joints to 90 degrees and then try to bend your DIPs actively. You'll find that is extremely hard. And that's because the advantage is lost because of the intrinsic relationships changing. So what happens is, if you flex the MP joints to this degree and you put a pin across, you cannot move the long flexors. as a result of which I think, and I may be wrong, the long flexors can get, adhesed at the fracture site and at the A1 pulley where there's a sharp curling of the tendon. I also use the retrograde technique, which I'll show you. Now, the one thing we did conclude, much like Robert, that intramedullary pins for phalangeal fractures work well. You do not need to have opposite cortical perches. The one thing I do differ with Robert is I prefer to use 2 pins, and that's because I worry about rotary control. When I think about one wire, I think about it as a round peg in a round hole. So I worry about the rotary control of the distal fragment. Agreed, you try to get perches in the subchondral bone of P1 head, but if that doesn't occur, can it also affect rotation? So that's one of my concerns. And the second is more practical. Anytime you leave percutaneous pins, there's a chance of getting an infection. So if you have 2 pins and if you have only 1 pin and you have to take it out, that compromises your fixation. But on the other hand, if you have 2 pins, you may still be able to save one. Here's the thing I was talking about, this person with a P1 fracture that looks very innocuous, but had crossover of the small finger at the ring finger, until we went and took the 20-degree elevated view. Now, what do I mean here? You see, the CMC joint shown by the yellow arrow is not seen clearly. But the minute you elevate it, what you're going to see is the fracture looks malaligned, and you can see your CMC is beautifully seen in profile. And so this was fixed with an intramedullary pin, just as Rob suggested, but I added a second wire, which is not intramedullary, to give me rotary control. And this is a 10-year follow-up. Similarly, for this fracture, we used cross pins, but we strayed intramedullary. And again, you get very predictable outcomes. So what are some of the technical tips? You obviously flex the MP joints to relax the intrinsics. You can use pointy reduction clamps, but I worry a little bit about compressing them too much. So I use Babcock forceps. So those of you who have done general surgery, you know that you can use Babcock forceps for appendectomies in the old days when you did open appendectomies. They are still available. I use 45 wires for the index and middle fingers, and 45-35 combo for the ring and small fingers. So these are the Babcock clamp. You apply it to the finger, and these holes that you see here, right here, you can put your pins through those holes without having to take the clamp off. It does make for a little tricky visualization of the fracture because these are not radiolucent. But it allows you to fix the fracture and get your pins in without actually compressing the fracture too much. Instead, you compress the soft tissue envelope, much like a Sarmiento brace that you use for fracture care. And the last thing I would say is, in fractures like this, which is a dog leash injury, which are violent twisting injuries, when you see so many fracture planes, I don't trust any method completely. So I prefer to go intramedullary, but I start distal. I cut off my sharp tips, and then I go. This is one of the few occasions where I use the Belsky technique. And you can see I try to engage as little as possible, keeping my metacarpophalangeal joints as close to extension as possible so that I can start DIP motion early so they don't get the FDP stuck down. And here's this person at about 2 months. So, great, thank you.
Great, thanks, Chai, for the presentation. And again, we'd encourage any questions that come through the chat. I wanted to ask Dr. Strauch and Dr. Mudgal and Dr. Darowish what your algorithm is for pinning proximal phalanx fractures. Do you generally try to start in periarticular fashion? And if you're having trouble, which I'm sure none of you ever do, then you convert to Eaton-Belsky, or do you start using the Belsky-Eaton or Eaton-Belsky technique? Dr. Strauch, well, why don't you have a start?
Yeah, most of these are the transverse proximal fractures, proximal third fractures that I'm doing pinning for. The long spiral ones, I'll usually put screws across them. I'll open it and put screws and get them moving right away. The other thing I just wanted to mention is that when we take the pins out at 3 weeks or 4 weeks, I'll give them a digital block in the office and then take the pins out and have them make a tight fist with both hands to try to rupture any of the flexor tendon adhesions.
I see.
And sometimes you'll feel them just, they have nothing, and then you have to sit with them for a few minutes, then it'll pull free, like a Xiaflex, popping a cord, and then they get a flexion back, but not always. Sometimes they're really stuck. So the question was, which type of fractures to pin? So I pin those, I do the Eaton-Belsky or Belsky-Eaton on the proximal third transverse fractures that are always apex palmar. The real question for me, I guess, at this point is when to start using those crossed screws. I haven't done that yet. There are some cannulated screws, such as that are being used for the intramedullary fixation of metacarpals now, that are being more commonly used for the proximal phalanx. Has anybody been using those, and do you like them?
No,
Go ahead, Chai.
I've used intramedullary screws for the proximal phalanx on only a handful of occasions, and I usually go antegrade. I worry about it. I don't go retrograde much like Del Piñal wanted popularized. I think it's a false equivalence to compare the P1 head to the metacarpal head, because the location of the starting point in the P1 head occupies a lot of real estate for articulation. So I worry about that, unlike the metacarpal head. So if I do put an intramedullary screw, it goes antegrade, and that I'm reasonably comfortable with.
Yeah, to go antegrade on the screw, you need to be able to subluxate the
Yes.
proximal phalanx, and
Yes.
some people can't. And so actually a transarticular technique through the metacarpal head has
Yes.
been described for that,
Yes.
as well as the crossed pinning, like your cross K-wire technique, but then putting screws over that.
And putting those screws, I struggle with one, so I don't know how much I do it too. So I'm sorry, I'm not that smart.
I agree. I think that I've played around with it in the lab, but trying to fit 2 headless screws into a small bone can be challenging to get 2 points of fixation. And to your question, Dr. Eberlin, I try to start extra articular, and once there's enough vulgarity out of my mouth, I'll switch to the transarticular. I warn my residents that the 3 cases you'll never look good doing are hardware removal, smart joint arthroscopy, and percutaneous pinning. And as soon as you're willing to admit that these look like they should be really easy and they will completely humble you, having bailout techniques or other tricks to when you're struggling to get that starting spot is really helpful.
Yeah, I do the periarticular pinning as a start, and if for any reason it becomes challenging, then I will bail out to the transarticular pin.
So I have a question for you, Dr. Mudgal. So you try to avoid the putting the MP joint flex down. When are you taking the pins out so as not to develop problems with the collateral ligament shortening because you don't have it down 90 degrees?
So I usually take out the pins by 3.5 weeks at the most. Usually, so if it's a metaphyseal fracture, even at 3 weeks, but if it's a shaft fracture, then 3.5 weeks. But like I said, Eaton-Belsky for me is less than 10% of the times.
But so even with your not, okay, I got you. And
Yeah.
with Dr. Strauch, when you said that you had your patients move right away, are you also doing that after the pins are out? Or do you have them do that release while the pins are still in? And then after they put that force across with the pins in, then remove the pins?
Well, we leave the PIP free in the splint, so that they can flex in the splint. And then when they come back to take the pins out, we'll take the pins out first, and then have them and block them, prior to that, so they're happy about that part, even though they don't really need anesthesia to take the pins out. And then have them do, active flexion, all the fingers, both hands at the same time, because sometimes they can't figure out how to do it with just one hand.
One of the, go ahead, Chai.
Michael, your point is well taken about the collaterals. So it's not like I try to get them as close to, but I don't try to get them down all the way to 90, because I see if you look in the cadaver and you look at the A1 pulley and the A2 pulley junction, when you flex the MP joint, it just accordions on itself. And that is exactly where location of most of these basal fractures is. So when you go in to do a tenolysis on them, inevitably when you lift up the tendons and you look down, that's exactly where they're spot welded. So that's why I worry about that.
Shai, I have one question actually for Kyle about your paper on the cross pinning, where you said that they didn't do so well if they had angulation of 20 or 30 degrees. Why do you think that was that on? I assume that was on the pre-reduction X-ray, but why do you think that was just a greater force of injury that they needed more tenolysis?
Kyle, you want me to take that?
Yeah, go ahead, Chai.
It was a long time ago, that paper.
Yeah, that was my series, and Kyle was kind enough to work on it and put it out there. Yeah, what I realized was I was a little squeamish about getting them moving at the IP joints. And I found that the people who didn't do well were the ones with a large angulation apex volar preoperatively. And my contention is that they bend so far that the floor of the flexor sheath is basically ruptured. And the periosteal injury is at the same level, as a result of which they get spot welding. So if they go that way, I tell them that there's a possibility they need flexor tenolysis. But since we wrote this paper, every time I see that, I will start them moving the DIP literally within 3 to 4 days.
Yeah, I think that's a really good pearl. Dr. Strauch, one point you highlighted in your slides was that there seems to be a general theme that fixing these fractures earlier seems to be have a salubrious outcome or effect on the outcome. If you see a patient in the office, let's say 3 or 4 days out from an injury like this, how soon are you getting them to the operating room?
If it's an operative fracture, a lot of these I can treat non-operatively, especially there are a lot of older people that come in with a small finger extra-articular base of the proximal phalanx that we can reduce and hold it and start them moving in a dorsal blocking splint, and they'll do okay. But many of those do get, a PIP contracture with or without surgery. They'll get a fixed PIP contracture for whatever reason. And so I'll try to get in, if it's an operative fracture, I'll try to get it as soon as possible. I wouldn't wait 2 weeks to get an OR data to bring them in.
Chai and Mike, do you guys agree with that?
Oh, absolutely. Absolutely.
Yes.
Great. I think Dr. Chim has a question, and then we'll go to the final chat question before we wrap up. Go ahead, Harvey.
Yeah, thanks, Kyle. And this is really a great discussion. I actually have a question that's kind of related to this, not related to the paper, but related to finger fractures. I wanted to know from the panel, what's your favorite technique for fixing unicondylar or bicondylar fractures? Because those are very difficult to fix because, they're intra-articular and small fragments.
Unicondylar fractures, usually for me, it's a combination of a threaded K-wire and a screw. And yeah, the pearl would be the threaded K-wire goes first and it stays subchondral, and that gives you control. And you can cut it, it behaves like a headless screw. And the screw goes after, making sure that the screw is inserted at the apex of the attachment of the collateral complex. And the thread should not engage the opposite collateral complex, because if it engages the opposite collateral complex, you'll lose flexion.
Yeah.
How about you, Rob and Mike?
The unicondylars, I used to open them. The major problem with those, and probably the bicondylars as well, is if you do a little too much dissection, it heals, and then 3 months later, that fragment undergoes AVN and the whole thing collapses to that side.
That's a difficult problem.
So I try to get them just closed with a towel clip or some kind of reduction clamp, and I'll just use 0.028 K wires, like 2 or 3, just to skewer it and keep them in about 3 weeks. The bicondylar ones are more difficult. Those have to be opened if they're displaced, I think. And
I think that Robert's point is very well taken. Whenever possible, pin them. But if you open them, then that's the construct I use.
And you start them moving really early, from what you alluded. Like, do you start them moving at like 2 or 3 weeks, or do you mobilize them longer?
For internal fixation, move them early. But if they are pins, 3 weeks. Pull out the pins, start moving.
Mike, do you do the same as well?
My favorite technique is when they show up in my partner's clinic and not mine. But yes, I tend to just pin them if possible. Rather than I agree, I try to not open them. And the other thing with these is that I am very upfront with patients that they are going to have a problem with stiffness. The literature shows that if you have a bicondylar fracture, none of them get normal motion. And so if you warn them ahead of time that they're going to have stiffness, it sort of sets the table that they understand that it's going to be good, but not normal. And I think that goes a long way in setting expectations.
Great. Outstanding. This was a really, really great discussion. I learned so much. I'm sure Carl did and our audience did as well. So, I'm so grateful for our authors and our expert, Dr. Mudgal, for joining us. So just to wrap up, CME can now be claimed for hand and focus. CME credits can be claimed once every 6 months for all webinars, 1 credit for webinar. And please look out for the next email to claim credits between April and May of next year. And thank you so much for your participation. Please continue to follow AHS on social media. Candidate membership for trainees is free. And please follow AHS and look out for the next journal club. So again, on behalf of everybody, the whole team at HAND and AHS, I'd like to thank again our authors, our expert, Dr. Mudgal, and for everybody for participating in the webinar tonight. Thank you so much, and have a good night, everybody.
Thank you very much.
Yep.
Thank you.
Thank you again, everyone. Good night.